My name is Professor Gareth Morgan. I'm at the Royal Marsden Hospital in London, England, where I head up the Hemato-Oncology unit. I'm here at the American Society of Hematology meeting and we're presenting results of the largest ever maintenance study looking at the role of thalidomide in myeloma. There are some really interesting results from this study. There are 800 patients randomized to the two arms of this study, and the basic data is that there's no improvement in survival based on being exposed to thalidomide maintenance. So this is an interesting study with an interesting design. In total, nearly 2,000 patients were accrued to the study, and they followed two pathways. Either an intensively treated pathway for the younger patients, where they were either induced with cyclothalidomide and dex, or CVAD. Then all of those patients went to high-dose melphalan, and then they were eligible for the maintenance randomization. For the older patients, they were randomized at presentation to either melphalan and prednisolone in standard doses, or to a thalidomide-containing regimen, cyclothalidomide and dex. And after 6 months of treatment for that, those patients were eligible for the maintenance randomization. The maintenance randomization was to either no treatment or to continuous thalidomide until disease relapse. The results of the study show that there was no improvement in overall survival for patients exposed to thalidomide maintenance. But that result belies rather more complexity, and the complexity is that while we did, in none of the situations could we show an improvement in overall survival for thalidomide maintenance, we could show an improvement in progression-free survival for patients who had suboptimal responses. And by suboptimal responses, I mean either a PR, which is not a VGPR, so anything greater than a VGPR, no, less than a VGPR, but greater than a MR. And so that group of patients benefited significantly in terms of progression-free survival. The consequence, though, of that improvement in progression-free survival is that when those patients relapsed, that their survival after relapse was less. We were also able to look at the impact of cytogenetics in this setting. And in this setting, we don't find that 13q has any impact on outcome, and 1114 doesn't have any impact on outcome. What you might think of as bad 14 translocation, so the 414, 1420, 1614, that group of patients have a worse outcome from the time of maintenance randomization, but there was no difference in the results of maintenance in that group compared to the other group. The other and important group of poor prognostic patients are those with 17p minus. And this is interesting in that overall it's a poor prognosis group. Those patients do badly in terms of overall survival. But that overall survival seems to be made worse by having thalidomide maintenance. And the implication of this is that before even contemplating long-term treatment with thalidomide, the patients need to be aware of their 17p status.